Now, I would like to call upon our chairpersons to chair the next session, which is on early post-op repair of bile duct injury, whether, when, and who. To chair this session, I would like to call upon our esteemed chairperson, Dr. Aleksandar Karamarkovic from Serbia. Sir is the director of University of Surgical Clinic Nikola, Spasic, UC Zvezdara, Serbia Hospital, University Surgical Clinic Nikola, Spasic, Faculty of Medicine, Belgrade. Chairperson to chair the session is Dr. Rajesh Bhojani sir. Bhojani sir had the Santokba Institute of Digestive Surgical Sciences at Santokba Durlabji Hospital, Jaipur, and is the program director for DNB in surgical gastroenterology and FNB in minimal access surgery. He is the president-elect of Society of Endo-Laparoscopic Surgeons of India. He is an editorial board member of Journal of Minimal Access Surgery and Indian Journal of Surgery, and also the associate editor of Journal of Bariatric Surgery.
Dr. Adarsh Chaudhary is a well-known figure of gastrointestinal surgery in North India, and the entire country, he has been the head of the department at GB Pant Hospital, the Department of GI Surgery, and he is presently heading the Department of GI Surgery at Medanta Hospital at Delhi, and he is a well-known figure for his two major surgical procedures, which are Whipple's and ulcerative colitis pouch. He has a lot of publications on bile duct injuries, and if I remember correctly, I think that was the first publication which had come on MRCP versus PT-gram and fistulogram was by Dr. Adarsh in the country. So with that, I think I hand over the mic to Dr. Adarsh Chaudhary.
So my talk is going to be very simple. A patient who has a post-cholecystectomy bile duct injury presents in 4 ways. There may be bile peritonitis, patient may have jaundice, or there may be leakage of bile from a subhepatic place drains, and some patients present late because of cholangitis. Patients who have bile peritonitis, needless to say, need emergency surgery. The aim of surgery is to drain the biliary collection, decrease sepsis. Patients who present with jaundice nearly always have a complete ligation of the bile duct, and a completely ligated bile duct is a serious issue because that's a recipe for disaster. Cholangitis can occur, and these patients need early intervention. Whenever the patient comes, patient needs surgery ASAP, because we have to convert that closed system into an open system. Patients who have a biliary fistula, like presenting with the bile leak, that's where the controversy lies. Should we operate them early or should we wait? And a subgroup of patients who present with cholangitis, there is no discussion because they present always late. So their presentation in them is always delayed. So a patient like this, like I already said, who presents with obstructive jaundice, there is no discussion. You need to do an hepaticojejunostomy whenever the patient comes, because a closed ductal system, like I said, needs a drainage. For some reasons, if you cannot operate these patients, you have to do a PTBD or something to let the bile out. So basically, the discussion of an early or delayed repair for a bile duct injury is relevant only to a patient who's got an external biliary fistula. Now, most of us who do biliary surgery whenever we operate for a patient who's got a subhepatic collection or something, this is the status which is in the abdomen. And we are taught from very beginning a basic surgical principle that no matter what a great surgeon you are, sutures do not hold well in presence of sepsis. Also, we also know that with the patient who's got a bile duct injury, the index operation is the best operation. With each failed repair, the stricture recedes higher, subsequent repairs become more complicated. So first intervention should be the best intervention. So based on that belief and the teaching that we have, that the bile ducts that we use for anastomosis should be healthy, they should not be inflamed, they should be capable of holding sutures, and we should make sure that we drain the entire biliary system. So that's why there was a unified perception of most biliary surgeons that a patient who presents with an external biliary fistula possibly is best managed by a delayed repair, because there is improvement in the 4 I's, that is improvement in inflammation, subhepatic infection, the immune competence of the patient. And also we know that a number of patients who have a bile duct injury have an associated injury to the hepatic artery. So it lets the stricture stabilize. So a stricture which may appear as E1 on postoperative day 1 might be E3 or E4 6 weeks later. And the most important advantage is that if you have to do a delayed repair, there are very high chances that this repair will be performed by a hepatobiliary pancreatic surgeon who's more facile in doing this surgery. What are the theoretical or possibly believed advantages of early repair? It is believed that if you operate early, you reduce the patient's burden, but I'm not sure what the burden is. Carrying a drain which is draining bile, to my mind, is not a burden, but that's a purported argument. There's a shorter hospital stay, it's believed, because it is done early, and since the hospital stay is shorter, it is believed that the costs are reduced. But this is a skewed belief that the costs are reduced. If you see the long-term results of failure and all, these patients needing subsequent procedures, the overall cost might be actually higher. So the question often asked is, okay, so what? What's the harm that if you do an early repair, it doesn't work? If it works, it's good. If it doesn't work, you can do a second repair. Like I already said, one of the basic determinants of outcomes after biliary stricture surgery is number of previous repairs. So I'm again reiterating the fact that the surgery for the hepaticojejunostomy you do should be single time, it should be effective, and it should be durable. So that's what the essence is. One of the areas of controversy or not adequate understanding in this field is we really do not know how to define the timing of biliary reconstruction. Various terms have been used, like the term of immediate repair or called as on-table repair. Like if you have an injury on the operation table and it is detected, there is no controversy that if you have an expert hepatobiliary surgeon available, the best time to repair that injury is at that time. But there's an important caveat that the surgeon should be competent to do that, because to repair a transected bile duct, which is normal caliber, where the injury has recently occurred, needs a lot of skill, a lot of competence, very good instruments, which most general surgeons do not have. So on-table repairs are ideal, provided done in tertiary centers or by expert surgeons. Other term used is an early repair, there's an intermediate timing, there's delayed. So there is a lot of ambiguity in literature about these terms. In this article, which was published from Holland in 2020, early repairs was labeled as repairs done within 2 weeks of injury, intermediate repairs were 2 to 6 weeks, and any repair after 6 weeks was regarded as a delayed repair. Another article which was published in 2019 divided the repairs into less than 1 week, 1 to 6 weeks, and 6 weeks to 6 months. So the exact timing has still not been decided, that what is really an early repair and what is a delayed repair. I've saved you all the unnecessary figures, and I just come straight to the meat of the whole subject. What does literature till today suggest? Most papers say that repairs performed between 2 to 6 weeks of injury have poor results. As expected, because bile duct at that time is inflamed, there is subhepatic inflammation, tissues are friable, and most hepatobiliary surgeons who do a lot of repairs believe delayed repairs are safer. There is no pressing argument to do an early repair most of the times. Like I said, on-table repairs only by hepatobiliary surgeons give excellent results. And there is also evidence in literature that at tertiary HPB units, repairs done at any time give good results as compared to repairs done by general surgeons. Many people quote articles like this, which has shown that early repairs give good results, but we should realize that these surgeons are a very highly skilled group of surgeons. This paper comes from a liver transplant unit where a lot of repairs were done on table and early repairs and gave long-term results. And I'm again reiterating the facts that skill and competence is of extreme importance in this delicate operation. Another question often asked is, who should be doing the repairs? Literature suggests that when injuries are handled by general surgeons, majority of these repairs are end-to-end repairs, which technically is easier, but majority of times fails. At that time, it looks satisfactory, but in the long term, these results are not good because doing a repair doesn't make any sense, which it doesn't work over long term. Success in biliary surgery is intervention-free, symptom-free patient for a long time, over 5 to 7 years, with near normal liver function tests. There's also evidence that repairs done by general surgeons are many times associated with inadequate preoperative workup. In a study which was published by Lawrence Way and Lygia Stewart, they showed that in nearly 30% of patients, biliomas were missed, vascular injuries were missed. So preoperative workup by a general surgeon is many times inadequate, and hepatobiliary pancreatic surgeons will nearly always do a hepatocholangiostomy. That's why the results of surgery are much better. So when is early reconstruction definitely indicated? When you have a patient who's got a jaundice due to complete ligation of bile duct, that is only when early repair is indicated. Otherwise, majority of surgeons today believe that delayed repairs, which means any times after 6 to 8 weeks after the bile duct injury, that's when the results of repair are the best. And this meta-analysis published in 2019, one of the largest meta-analysis, again reiterates the same fact that delayed repairs over long term give good results. Early repairs give good results if done by hepatobiliary pancreatic surgeons, but there are very few indications today to really do an early repair, and there is no pressing need to press the panic button and try to operate these patients before 6 to 8 weeks. And like Colin Powell said in the Gulf War, that the trick in biliary surgery also is to make timely decisions and not quick decisions. So waiting is the best thing. Repair should be done by a hepatobiliary pancreatic surgeon. If you have a transaction on the table, I'm sure it's been discussed in the morning also, is best done by a trained surgeon. So I'll be very happy to answer questions if there are any. Thank you very much.
Dr. Bhojwani, sir.
Thank you, sir. This is Rajesh Bhojwani. I hope I'm audible. Thank you for a very, very precise and summarized talk as usual, as ever, with crisp take-home messages. I would just like to mention here that I've been Sir's student and he has been my mentor and teacher And till date, somehow, our roots have been so strongly made that we all follow the same pattern and the surgical principles. And I would also agree in my own practice that there is hardly any place for early repairs in my own practice as such. Can we please have the questions? And may I please invite my co-chairperson, Dr. Aleksandar from Serbia, for his comments.
Yes. Greetings from Belgrade. Thank you very much for this kind invitation. And I would like to congratulate the colleague for the very nice overview, very nice presentation about this, let's say, real surgical life in everyday surgical practice. We are dealing with a lot of especially lap cholecystectomy. So the problem is here, how to manage, when to manage. I would say that we have a little bit different situation regarding the organization of the surgical service here in Serbia, because we account on German system. Many of general surgeons are available to perform some initial steps in order to repair the bile duct injury. It's not strictly a difference between the general surgeons and HPB surgeons like in England, like in India, for example. So, but I completely agree with you with your presentation. Nothing to add, nothing more. Yeah.
Thank you so much. You come from a beautiful country, and I absolutely agree that if you have the luxury of a HPB surgeon, it's good. If you don't have it, then you have to manage with what you have. I absolutely agree.
I'm personally HPB, so
you must be in demand.
yeah. But for example, in my hospital, I'm the only one who is performed HPB. I mean, pancreatic hepatobiliary surgery. So there is no problem for when we have injury. I'm here on duty, on call. Never mind. We can manage the injury. But the lot of colleagues in my previous hospital, they try to do early reconstruction, to put some stitches, to make some end-to-end anastomosis with T-tube, so on. For high-level reconstruction, you have to very experienced HPB surgeon. There is no doubt about this comment.
Can I make a comment?
Dr. Ardnari has a comment, it seems.
Can you hear me?
Yeah.
Yes, sir, you're audible. Yes, sir.
Yeah. Okay.
Yes, sir.
I completely agree with Adarsh. As a matter of fact, if you read the papers carefully, which have advocated early repair, you will always find that they have had a couple of mortalities in the series, both from Edinburgh and in the combined series. And if you manage them conservatively when they come to you by first draining the pus sepsis and then doing a delayed repair, there's virtually no mortality if done by, as Adarsh said, HPB surgeon. So like Adarsh, and I think like most Indian surgeons, I am a strong believer of delayed surgery. Wait for the fistula to close, wait for the ducts to dilate. And in that process, there is a small percentage, about 5 to 10% of patients who develop some internal fistula somewhere, and then they have no leaks, no jaundice, LFT is perfectly normal, and they are under observation for many years and they don't develop any other problems, no cholangitis, nothing. So, and if you can follow them up, why operate at all? Thank you.
Can I, if there's no question, can I?
So please unmute yourself. Yeah.
I said, can I cross swords with Ramesh on this? Whenever we have time?
Yes, sir. So there is one more question. Transected CBD with drain in situ. When to intervene? There's a question from some other student.
So I said, if you have a patient who's got a transected CBD, obviously somebody who's draining bile has a hole in the bile duct. So you should wait at least 6 to 8 weeks, at least. My reason for waiting is not for ducts to dilate. My reason for waiting is simply that I want the subhepatic inflammation to settle, the inflammation in the bile duct to get well, so that once I do a hepatojejunostomy, my sutures hold. So when you operate these patients, the subhepatic space should be dry. The Johns Hopkins people go the other extreme. In every patient of biliary fistula, they put a PTBD to keep the subhepatic space dry. So that absolutely reiterates the fact that if you have no inflammation in the subhepatic space, your bile ducts are healthy, your anastomosis is going to do well in the long term.
I think very valid answer. Can I get you to some controversy which we had in the morning as well?
Yep.
There was a controversy of hepatojejunostomy, rule of hepatojejunostomy versus duodenojejunostomy.
There's a simple thing. Some of us want to be famous by just playing to the exception to the rule. Why do you want to do hepatojejunostomy? This makes no sense. You can do a hepatojejunostomy. I see no sense. Because if you think that your anastomosis is going to, if it gets stenosed, you can open it by an endoscopy, they are gimmicks. So you should just do a proper hepatojejunostomy. To my sense, it makes no sense to put duodenum into it. I
think the duodenum comes because many pediatric surgeons prefer to do cold cysts with the duodenojejunostomy.
And I have personally undone so many of them.
I know. I personally don't have any support for that. Yeah, even in cold cysts in children, I believe hepatojejunostomy is still the answer.
Absolutely. Just because a procedure is in life, there is a difference between what is easy and what is right. So we should do what is right, not what is easy.
Dr. Mathur has a comment, precise talk, Dr. Adarsh, in agreement with philosophy of delayed repair. Dr. Vishal has a question. How long to wait with the high output external biliary fistula?
In my life, I have not seen a patient who's got an isolated bile duct injury with a high output fistula. If you have a patient in whom the fistula output is very high, many times they have an associated duodenal injury. Majority of time, the highest bile I've seen is about 400 to 500 ml of bile. If I have rarely ever need to operate a patient because of fluid electrolyte balance because of bile output. It's very unusual.
I think what he wants to know is possibly persisting fistula output in the drain after 6 weeks, 8 weeks, the patient has around 100.
We'll operate. So you have waited 6 to 8 weeks, then you operate these patients.
I think the message is clear. After 6 to 8 weeks, even if the fistula has some bile drain, I think you can go ahead and do a hepatojejunostomy.
If you ask me my belief,
yes,
I push patients for 10 weeks, 12 weeks, 14 weeks, because if they can wait that long, it definitely makes a difference.
And most of them will close at that time and the ducts will dilate. That's what I was trying to say.
Absolutely, absolutely.
Yes.
Yeah. General Chaube has a question, Dr. Chaube.
In fact,
Professor Adarsh, your talk was on early BDI injury, early repair, and you said that you have said that you are totally against it. But then this was the story. 2 or maybe 3 decades back. And this concept has come. People are repairing. And the question is, if a patient has come to you next day, has been referred to you next day, and you have a sick drain, and you do the ultrasound, there is no collection inside, there is no sepsis, will you repair, or you will let the patient continue for 10 weeks and then do the repair?
Okay. The answer to this question is, have you finished?
Yeah.
The answer to this question is, if I say, yes, I will operate the one who comes within next day. Your next question will be 2 days, 3 days. These things are not rules of thumb. What I'm saying is, if you want me to tell you, if a patient comes to me within 48, 72 hours, I will operate these patients. But somebody who comes late, you might say, why not 4 days? So what I'm saying is, we need to have a broad perspective to things. It's not rules of thumb that is, this line doesn't have to be crossed. I only want there should be no inflammation in the subhepatic space and suture should hold. So that's my answer to this question.
I think I would like to add to Adarsh's thing. He didn't quote this paper.
If I may please be allowed. Yeah.
There's a paper from Norway where HPB surgeons only repair bile duct injuries, and they did early repairs. Patients were transported after the injuries. And when they analyzed the data, they found that there's a 30% higher stricture rate in those who had early surgery done by expert HPB surgeons. So I think...
Ramesh, do not understand what is the panic.
I know.
What's the panic?
No panic.
You have one chance of repair.
And wait.
May I ask you, Professor Chaudhary, something?
Yeah.
Can you hear me? You didn't mention, but I would like to ask you, how do you manage some associated vascular injury? Vascular injuries? I mean, especially the right hepatic artery, when you discovered at the moment of the intervention, or let's say re-intervention.
So, if on the operation table, by the time you are called, most of the time the damage is done. But later on, patients who present to me, I have never reconstructed a right hepatic artery in my life. I have repaired a couple of intraoperative injuries, but I have not reconstructed the right hepatic artery. And subsequently also, we always document the presence of an injury to right hepatic artery, but we do not think it is necessary to reconstruct it, because no matter where the injury is, the anastomosis always lies in the left duct. You'll agree with me on this.
Thank you.
Last question, Dr. Bhojwani wanted to conclude something. Last remark.
Just before concluding, if I may be allowed to mention, because our country, India, is not a very perfectly organized referral system. I feel this concept of early repair, at least in India, is a function of the primary surgeon's anxiety, patient's impatience, and the repairing surgeon's excitement about coming up with something which is very heroic. And as the surgeon matures, he realizes there is no fun in opting for such heroic measures, which eventually do not benefit the patient, perhaps. With that, maybe we can conclude the session. Thank you very much, sir, Dr. Chaudhary, sir, and Dr. Kapoor, sir, for inviting me over.
I only have one comment to make, if Vinay and Ajay permit me.
Yes, sir, please, it's a pleasure.
My biggest question always is that we always propose a mucosa to mucosa anastomosis, and still it strictures. But the endoscope is sparse-stent. There is no mucosa to mucosa anastomosis, and still it works. This is magic. I don't understand.
Sir, this was a question I had written. I could not ask that because Dr. Saraswat is sitting in the audience. So I thought, let me get this into discussion now. So I think, yeah, that is a discussion which is an unending discussion.
Thank you.
Okay, Dr. Saraswat says it's a matter of time.
Okay.
So we can discuss it some other time. I think, yes.
Thank you.
Thank you, sir, for the nice presentation.
Thank you.
Thank you very much, Adarsh sir, for such a nice presentation regarding the bile duct injuries. And thank you very much, Bhojwani sir, to chair the session, Dr. Alexander sir, to chair the session.
Thank you, Dr. Alexander, for joining. Thank you very much.
Thank you. It was my pleasure. Bye-bye.
Thank you. Bye.